sternoclavicular joint becomes sore, the patient tends to adapt to protracted posture with chin poke. The arm rests in internal rotation, and the adaptive posture contributes to pectoralis major becoming short, tight and overactive. The external rotators weaken and the problem spirals. The pectoralis major's overdominance can lead to anterior subluxation of the sternoclavicular joint. With time, this becomes habitual and occurs often every time they elevate their arm. The chin poke posture that patients adapt also can lead to sternocleidomastoid becoming overdominant, again leading to instability. Contributing factors include hypermobility, posture, scapular position and cuff power. Often when the pectoralis major becomes extremely overdominant, it fires even when the patient attempts to externally rotate. Assess for slumped posture, internally rotated arm and reluctance to elevate. In normal movement, the hand should be in neutral rotation, ready to grasp an object, with the shoulders rolled to place the hand ready for function. Patients apprehensive of the sternoclavicular joint subluxing on movement tend to fix into internal rotation with the thumb placed downward or forcefully grip their hand, which is not productive for function and increases the activity of the pecs. And the overactivity pulls on the sternoclavicular joint when the patient stands upright, therefore the patient avoids this and slumps. On elevation, often at 90 to 120 degrees, the pectoralis major anterior pull causes the medial end of the clavicle to sublux anteriorly. The patient is often reluctant to elevate any higher or may be able to relocate to achieve full movement. Abduction is often worse for the patient as it pulls on the pectoralis major on further stretch than flexion does. Muscle power of infraspinatus is often weak on clinical assessment. When infraspinatus becomes weak, the patient compensates by recruiting into abduction or adduction with the shoulder to stabilise, effectively appearing to demonstrate better power. Compensating by flexing the elbow using biceps can also present as more power than the patient actually has. To test infraspinatus power, ensure that the elbow remains at 90 degrees flexion, tucked in at the patient's side but with a little space between the body and the elbow to avoid fixing into adduction whilst measuring power. Observe the pec major to see if a band appears when assessing external rotation power. As an internal rotator, this should not activate. If it does, this suggests that the patient is fixing for stability, which effectively contributes to the instability. Treatment baseline, or the start point, should be based on the improvement test that corrects the instability. The improvement test is positive if it enables the patient to elevate further whilst maintaining a stable sternoclavicular joint. The overall aim is to go through full range while staying in joint and being comfortable, but this is not always achievable on the first assessment. Any improve in range or stability is a good indicator that the patient will respond well to a course of physiotherapy. The immediate improvement in their range or stability is an excellent motivator to show the patient that their symptoms can improve with exercise and help gain compliance. The patient stands in a relaxed upright posture with their elbow bent at their side. The physiotherapist asks the patients to gently push their hand to facilitate the external rotation. The patient is encouraged to maintain the external rotation force whilst elevating their arm. Correcting chin poke, protracted shoulder girdle posture by encouraging scapular retraction, cervical retraction and abdominal pull-in whilst elevating the arm. So coming from a forward slump posture with the head down, coming up, activating, going up onto tiptoes and going through full range and retracting the cervical spine. The patient performs a lunge and trunk rotation whilst elevating the arm. And this may vary as to which leg works for that patient. So try both sides. patient is then taught an exercise to mimic the improvement test as their home exercise programme. For example, infraspinatus facilitation, using a light resistance band, holding between the hands with the thumbs facing upwards, gently pull out to facilitate external rotation, maintain this contraction whilst raising up and back down. You may want to combine this with working the kinetic chain by going into a lunge and performing the V sign. Scapular settings. Scapular and cervical retraction exercises or core work. A good example is performing a table push, so working the kinetic chain, going into a slight squat, putting the hands back on the table, head forwards and pushing back and retracting, holding and relaxing down. Kinetic chain exercises, for example, working into a lunge and trunk rotation. For example, doing the lawnmower exercise using TheraBand or a weight, going into a lunge and pulling up on the band, putting in trunk rotation and elevating through range. Ensuring that the patient can demonstrate a good home exercise programme technique, that is, that the instability is corrected and pectoralis major or sternocleidomastoid overactivity is reduced and they remain relaxed, is vital. The number of repetitions should be guided by how many the patient can control. It is essential that the patient is educated regarding the aim of the exercises and understands the underlying concepts. Functional exercises. Once the patient can control stability through range, the patient can progress to functional exercises, recruit the rotator cuff in combined movements involving the whole body, and finally progress to ballistic or plyometric exercises if needed, for example, sports people. Patients often have setbacks during treatment, so should be regressed to their baseline exercises if necessary. How quickly they respond to treatment varies and is heavily dependent on compliance and the patient's understanding of the aim of the exercises. The length of treatment does vary depending on how quickly the patient adapts and progresses, but generally at least a 6-month course of physiotherapy is required, with appointments initially being 1 to 2 weekly, then 3 to 4 weekly up to 6 weeks as they allow time to master the exercises. If you have any questions, I'll be happy to respond via email to this address.